Welcome to the image analysis of the foot. We're going to review common foot projections of the AP axial, the internal oblique, and the lateral projection of the foot. We're going to review the image analysis guidelines, common positioning errors, and how to take corrective action. Image analysis guidelines for the AP axial projection state equal spacing between the 2nd through 5th metatarsals should be demonstrated. 1/3 of the talus is superimposing the calcaneus. The joint space between the medial 1st and intermediate 2nd cuneiform should be demonstrated as open. The tarso-metatarsal and navicular cuneiform joint spaces should be demonstrated as open. The 3rd metatarsal base is at the center of the exposure field. The proximal calcaneus, talar neck, tarsals, metatarsals, phalanges, and the foot soft tissue are all to be included within the exposure field. Here are those image analysis guidelines for your review. Understanding foot rotation is essential for properly positioning the foot in an AP projection. The medial longitudinal arch causes the medial plantar surface of the foot to rise up off that image receptor. This makes it crucial to position the foot so that even pressure is distributed across the entire plantar surface, which helps prevent that medial or lateral rotation. Uneven pressure or rotation can result when the ankle is allowed to invert or evert due to misalignment of the lower leg, ankle, and foot. This is especially important in non-weight-bearing AP foot projections. In weight-bearing foot projections, improper rotation can also occur when the knees and the feet are placed too close together or too far apart instead of at hip width. Now, let's look at how rotation affects the image. Lateral rotation of the foot causes an increased superimposition of the metatarsal bases. The medial and intermediate cuneiform joint appear to be closed. The talus moves over the calcaneus, resulting in more than 1/3 of the talus overlapping the calcaneus. In contrast with medial rotation, it results in a decreased superimposition of metatarsal bases. There will be a closure of the medial and intermediate cuneiform joint, and the talus seems to move away from the calcaneus. Carefully analyzing these features and these relationships will help you identify and correct any rotational errors when for your AP foot projections. So now let's talk about central ray angulation and the medial longitudinal arch and its relationship. The height of individual's arch will vary from patient to patient and is influenced by the condition of that patient's ligaments and muscles. When these structures weaken or fail, the arch lowers. As a result, the tarsometatarsal and navicular cuneiform joint spaces shift, changing the angle and relationship to the image receptor. To open these joint spaces on an AP foot projection, the central ray must be angled to match the slope of that arch. This is typically achieved with using that 10 to 15 degree proximal central ray angle. A lower arch angle would take a closer to 10 degree angulation for patients who are more flat-footed. A person with a higher arch would require a central ray angulation of closer to 15 degrees. Correct central ray angulation is essential for diagnostic image quality and avoiding that joint space distortion. Let's assess this first AP axial foot practice analysis together. First, we want to determine whether we have all our anatomic structures. Next, we want to look for any anatomic relationships that are apparent. We definitely want to make sure all our joint spaces are open, and we want to ensure there is no rotation one way or the other on the AP axial projection. In this case, we have some closed joint spaces, which is the tarsometatarsal joint spaces. This should indicate to you that the central ray was not aligned appropriately with these joint spaces. In order to take corrective action, we need to increase that central ray to 10 to 15 degrees in order to open up that TMT joint space. Let's review this practice analysis together. We want to evaluate for rotation, if our joint spaces are open, and the places in which our metatarsal bases are laying. In this case, the joint spaces between the medial and intermediate cuneiform are closed. This can indicate some rotation here. The talus superimposition on the calcaneus is decreased, as well as the superimposition of the metatarsal bases has decreased. This should indicate to you that the foot is medially rotated. In order to take corrective action, we need to laterally rotate that foot into a true AP position. Let's move on to the AP oblique projection of the foot. Image analysis guidelines for the AP oblique projection state that the cuboid cuneiform and 3rd through 5th intermetatarsal joint spaces are demonstrated as open. The sinus tarsi and the 5th metatarsal tuberosity are visualized. The 3rd metatarsal base is at the center of the exposure field. The phalanges, the metatarsals, tarsals, calcaneus, and foot soft tissue are all included within the exposure field. Here are those image analysis guidelines for your review. The degree of foot obliquity required for an accurate AP oblique foot projection depends largely on the patient's medial longitudinal arch height. Higher arches require more rotation to open that cuboid cuneiform joint space and the 2nd through 5th intermetatarsal joint spaces. This image here illustrates properly positioned AP oblique foot projections in patients with low, average, and high arches. All 3 images demonstrate open joint spaces, but each require a different amount of obliquity, which can be seen in the amount of 1st and 2nd metatarsal base superimposition and the spacing between the metatarsal heads. As the foot is rotated medially, the 1st metatarsal base moves beneath the 2nd, increasing that superimposition. This is a visual cue that helps assess how much the foot has actually been rotated. You can also determine the necessity of the degree of obliquity based on the central ray angulation utilized for your AP foot projection, especially when the central ray was aligned perpendicular to the dorsal foot surface. If in your AP axial projection you use a 5-degree, which indicates a low arch, then you would require a 30-degree amount of foot obliquity. If you had to increase to 10-degree central ray angulation for your AP axial, then for the oblique you would rotate the foot generally 45 degrees of obliquity. If you had to increase that angle, central ray angulation for that AP axial projection to 15 degrees, that reflects a high arch, and that would require a 60 degrees of obliquity for that oblique projection. Accurately adjusting the foot obliquity based on the arch height ensures proper joint space visualization and optimal image quality. Proper foot obliquity is essential for obtaining a diagnostic AP oblique foot projection. Let's look at how to identify insufficient or excessive rotation. Insufficient foot obliquity occurs when the foot is not rotated enough. In this case, the longitudinally running joints, including the cuneiform, cuboid, navicular cuboid, and the 3rd through 5th inner metatarsal joint spaces, will all appear closed. To determine if the rotation is too little, you want to evaluate the joint space between the 4th and 5th metatarsals. If the 4th and 5th metatarsal bases are superimposing if the 4th metatarsal base is superimposing the 5th, this indicates insufficient rotation. On the other hand, an excessive foot obliquity will occur when the foot is over-rotated. In this case, the 4th and 5th intermetatarsal joint space will be closed again, but now the 5th proximal metatarsal appears in profile and then superimposes the 4th metatarsal tubercle. Recognizing these positioning errors ensures more accurate foot imaging and minimizes the need to repeat. Let's review this practice analysis of the AP oblique foot together. We want to look at those key relationships between the cuneiform cuboid, navicular cuboid, and the 4th metatarsal and 5th metatarsal superimposition. In this case, those joint spaces are closed, okay? And the 4th and metatarsal tubercle is shown without superimposition of the 5th metatarsal. This should indicate to you we are under or insufficiently rotated. We need to increase the degree of medial foot rotation to open up these joint spaces and get a more diagnostic image. In this practice analysis, again, we want to evaluate those key joint spaces between the cuneiform and cuboid and the navicular and the intermetatarsal joint spaces. They're closed again. Okay, now we have to determine, are we rotated insufficiently or excessively? So we want to look at that key relationship between the 5th proximal metatarsal and the 4th metatarsal tubercle. They are superimposed. This indicates that we're excessively medially rotated. In order to take corrective action, we need to decrease that medial foot rotation in order to achieve a more diagnostic image. Let's move on to our lateral foot projection. Image analysis guidelines for the lateral foot projection state that the metatarsal heads are to be superimposed. The lower leg and foot should be at a 90-degree angle with a neutral ankle joint. The proximal talar domes are aligned. The tibio-talar joint is open. The distal fibula is demonstrated about a 1/4 inch distal to the distal aspect of the medial tibia. In a average medial arch, 1/2 of the cuboid is visualized posteriorly to the navicular bone. The talar domes are aligned anteriorly and posteriorly. The anterior aspect of the distal fibula is aligned with the mid-tibia. The posterior half of the distal tibia superimposes the fibula. The distal tarsals are at the center of the exposure field. The phalanges, metatarsals, tarsals, talus, calcaneus, 1 inch of the distal lower leg, and foot soft tissue are all included within the exposure field. The first projection is appears to be accurate positioning with standing, and the second is lying down or recumbent. Here are the image analysis guidelines for your review. Please review these images. They are all accurately positioned lateral projections of the foot. The key anatomic relationships that I want you to notice is that each one of these patients have a different medial longitudinal arch. In an average medial longitudinal arch, notice the position of the cuboid in comparison to the low and high arch. In a high arch, you're going to see more of that cuboid than you do in a low arch. But the key thing to remember here is that we have talar dome superimposed and that the metatarsal heads are superimposed. Correct alignment of the talar domes is crucial for a diagnostic lateral foot projection. When the lateral surface of the foot is placed parallel to the IR and even pressure is applied across the entire surface, the anterior and posterior aspects of the talar domes appear aligned. This indicates proper positioning. However, if one talar dome appears anterior or posterior to the other, this suggests improper leg rotation. To correct it, you really want to evaluate the position of the fibula in relationship to the tibia. Let's break this down for you a little bit more. If the leg is not externally rotated enough, more pressure shifts towards the heel. This results in the lateral talar dome being positioned anterior to the medial dome and the anterior fibula appearing anterior to the mid-tibia. Here's a review of those characteristics for internal rotation and how to take corrective action. Now let's take a look at what external leg rotation looks like. If the leg is over-rotated externally, more pressure is placed on the forefoot. In this case, the lateral talar dome will appear posterior to the medial dome, and the anterior fibula shifts posterior to the mid-tibia. Understanding these relationships between the talar dome positioning and the fibula alignment helps you to ensure precise lateral foot imaging and reducing the need for repeat exposures when you take the corrective action. Here are those characteristics for your review and how to take corrective action. So now let's take a closer look at how elevation of the lower leg, either proximally or distally, will affect the appearance of a lateral foot projection. If the proximal lower leg is elevated higher than the distal end, there's several key signs that appear on the radiograph. The lateral talar dome is demonstrated proximally to the medial talar dome. Less than ½ inch of the cuboid is visible posterior to the navicular bone, assuming that the patient has an average medial arch. The distal fibula will appear less than a ½ inch distal to or even proximal to the distal medial tibia. Both the talocalcaneal and tibiotalar joint spaces will be closed. In order to correct this, you'll have to depress the lower leg by extending the knee or elevating the distal leg using a sponge. Now, if the distal lower leg is elevated above the proximal portion, the lateral talar dome will appear distal to the medial dome. More than ½ inch of the cuboid is demonstrated posterior to the navicular. The distal fibula is positioned more than ½ inch distal to the medial tibia. And the talocalcaneal joint space will be open while the tibiotalar remains closed. To correct this, we need to depress the distal lower leg to take corrective action. Understanding these anatomic relationships will help you when you need to take corrective action. Let's review this lateral practice analysis. The anatomic relationships of interest is we want to determine, are our talar domes superimposed? Are our metatarsal bases superimposed for this metatarsal head superimposed for this lateral projection? And in this case, they are not. If you look at the medial talar dome is anterior to the lateral. The fibula is a position posterior to the tibia, which should indicate to you on this cross table that the leg was externally rotated. Also, the foot is in plantar flexion. In order to take corrective action, we need to dorsiflex the foot and internally rotate that leg until the lateral foot surface is parallel with the IR. Let's review this next practice analysis together. Again, we want to look for an open tibiotalar joint space. We want to look for our talar domes to be superimposed, the metatarsal heads to be superimposed. In the position of the tibia and fibula. In this case, the fibula is anterior to its normal position on the tibia. The medial talar dome is posterior to the lateral. This should indicate to you that the leg was internally rotated. We need to externally rotate that leg until the lateral foot surface is parallel with the IR to ensure a true lateral projection. Let's evaluate this last practice analysis. We really want to evaluate whether we have an open tibio-talar joint space. We want to evaluate our position of the tib fib, and we want to evaluate whether our talar domes are superimposed. And in this case, the lateral talar dome is demonstrated proximal to the medial. Less than half of that cuboid is visible posterior to the navicular. Our joint spaces of the talocalcaneal and tibiotalar are closed. This is all indicators that we have an elevation issue rather than a rotation issue. The proximal lower leg is elevated above the distal lower leg, and the foot is in slight plantar flexion. In order to correct this, we need to depress the proximal lower leg and dorsiflex the foot more for the next projection. This concludes our evaluation and image analysis of the foot. If you have any questions, please feel free to reach out. Thank you.